Good morning, everyone. We'll get started in just a moment, letting people join. Good morning. So glad the chat's working. Good to see you all here. Okay. Welcome to the Kentucky Harm Reduction and Recovery Community of Practice webinar series presented by Voices of Hope and the University of Kentucky Harm Reduction Hub. The goal of a community of practice is to bring together a group to engage in training, share best practices, and network around a common interest. Today, the topic of our community of practice is about the co-creation of a toolkit for peers to share drug checking results. First, we'll hear from Kacey Byczek, Community Research Associate, who is providing an update from the University of Kentucky Harm Reduction Hub. Then we'll hear from Martha Tillson, Research Assistant Professor of Behavioral Science at the University of Kentucky, who will discuss the toolkit for peers to share drug checking results. So before we hear from Kacey, though, we've got a couple of housekeeping notes. So the chat's on, the chat's working. We encourage you to participate, to ask questions. If you put a question in the chat and it seems like maybe it kind of got lost in the chat, just know that me and Amanda are watching for those, and we're going to try to get every question answered that you may have. And if you are a peer support specialist interested in continuing education credit for this webinar, you'll need to complete the survey that we'll place at the chat toward the end of the session. So keep an eye on the chat for the end of the webinar, where we'll put the link for the survey to get the CE credit. Okay, so now I'll introduce you to Kacey, a harm reductionist with over a decade of experience working in syringe service programs, advocacy organizations, and community-driven research studies. Kacey has held direct service roles at syringe service programs in New York, and Louisville, Kentucky, and has provided training and technical assistance on working with people who use drugs and/or trade sex to harm reduction programs and health departments across the country. Kacey came to harm reduction work through lived experience of substance use and a desire to keep herself and her community as safe as possible. As Community Research Associate at the Harm Reduction Hub, Kacey will provide monthly updates on the Hub syringe residue testing project on this webinar, as well as harm reduction education about emerging adulterants in the drug supply. So welcome, Kacey. I'll turn it over to you.
Thank you so much, Brooke. Hi, everyone. I'm so excited to be with you today, and I'm going to go ahead and share my screen, and we'll get started. All right. So as you heard, my name is Kacey Byczek. I'm Community Research Associate on the UK Harm Reduction Hub. And I'm going to talk to you a little bit today about the hub. I know that you heard about it from Dr. Vickers-Smith a couple months ago, but I'm just going to give you a brief overview of what it is for anyone who might have missed that, and a very brief overview of our testing process, and then I'll talk about our July and August results. All right, so that is our quick agenda. We're going to spotlight two contaminants and substances that have come up in the residue this month, carfentanil and medetomidine, and you'll hear more about those, of course, in about 10 minutes. First, I just wanted to give a little bit of overview of who I am. I know that Brooke just read my bio as well. As she said, I'm a longtime harm reductionist, got into this work through lived experience and a desire to keep myself, my friends, my community safe. I have worked at a program called the Lower East Side Harm Reduction Center in New York City and at Louisville Metro Department of Health's harm reduction program as well. I also worked at the National Harm Reduction Coalition and as an independent consultant, providing training and technical assistance nationally to harm reduction programs, state and local health departments, and other organizations, as you heard. I'm a person with lived experience of opioid use disorder and recovery using buprenorphine, and I really feel and advocate for the validity of non-traditional recovery pathways. So practicing harm reduction, I always say that, like, to me, it is as important to celebrate someone who has used a sterile syringe every time they've injected for the past decade as it is to celebrate someone who has been completely sober from any substances that they have problematic relationships with for the past decade. Moderating use, again, if people are able to change their relationship with a substance and moderate their use, I think that is great and a totally valid form of recovery. And of course, I believe abstinence is a valid form of recovery as well, whether from some or all substances. So just an advocate for widening our perspective on what recovery is and can be. All right, so now that I've introduced myself, I'm going to talk a little bit about the Harm Reduction Hub and who we are. So the Hub is an initiative that brings together a team of academic and community-based scientists and harm reductionists with the goal of providing early insights into the street drug supply in Kentucky by analyzing residue in used syringes. The Hub exists first and foremost as a service. So there may be research projects that happen under the umbrella of the Hub, but we are a community service, and that our focus is always on providing information to people who use drugs and the programs that serve them. And we really believe that two-way feedback loops with our partners are critical to our Hub's success. So we get feedback from our community partners who we get our syringes from. We also have a steering committee made up of a variety of experts, people who, medical experts, people who are working in harm reduction, people with lived and living experience who advise us on the project, because we want to make sure that the voices of the people who are using drugs and people who are doing the work with people who are using drugs are heard and reflected in our work. So I just want to give you a brief introduction to our Harm Reduction Hub team. I believe everyone, if not everyone, are on the webinar today. You all know Dr. Amanda Fallon Bennett, who is one of our co-project leads. And I know that you've all heard from Dr. Rachel Vickers-Smith before. She's our other co-project lead. Brooke Hiltz is our project director. Mike Ward is our toxicology lead and a co-investigator on the project. Kelly Harp is a forensic scientist on the project. Naomi Cheek is our project assistant. Preston Tolbert is our research analyst who helps us with our REDCap and data stuff. And I am community research associate. So I will be presenting at these webinars. When you get newsletters from us, I'll be the person sending those out. I will communicate with our external partners, and I chair the steering committee. So that's our team. It's a really great, exciting group of people. And you can always reach us at ukharmreductionhub@uky.edu. And we will get back to you if you have any questions, concerns, thoughts. You can email us there. I also put my own email on this slide if you ever want to get in touch with me directly. All right, so just a quick overview of how syringe residue testing works. And I do want to say that we are hoping next month to have Mike and Kelly, who do our residue testing, on this webinar for an interview and for giving much more detail about the residue testing process than I can give as someone who is not a chemist, not a scientist, doesn't work in a lab. So our lab is run by Professor Mike Ward, who's a certified toxicological chemist with 33 years experience as a forensic toxicologist at the Kentucky Medical Examiner's Office. And then Kelly Harp is our lab technician and also does much of our residue testing. In the future, we are going to have internships that students can complete to gain experience in the lab testing real-world street drugs and work with partners to develop communication strategies around communicating about the contaminants found in the drugs, and just learning how to communicate with those important partners. And as I said, Mike and Kelly will join us during a future webinar, hopefully next month, to talk about the residue testing process in more detail. So if you have questions about how that works, they will be able to answer them at that time. All right. Oh, sorry, my slideshow won't advance. Okay, there we go. All right, so I just want to give you an overview of our testing results from both July and August. So in July of this year, Mike and Kelly tested residue from about 350 syringes, 349, all from Jefferson County. Of these, about a third tested negative for detectable substances, and 224 tested positive for substances and adulterants. The most frequently found substances in July were meth and fentanyl, with 179 syringes containing meth and 109 containing fentanyl. And of course, there's some overlap there. So here are the results. We pulled out just the meth, fentanyl, and xylazine results because those were the drugs that are frequently found, as well as xylazine is a substance and adulterant that is frequently found, and that I know that a lot of programs and people who use drugs are in conversation about right now. So about 2/3 of the positive, the syringes with positive residue results had meth in them, or just meth, and then about 15% had just fentanyl. Um, about 11% had a mix or had both meth and fentanyl in the residue. And so that could have meant that there was a mix of meth and fentanyl, or that someone was reusing their syringes, using meth in once and fentanyl in the other. We don't really have, we can't really know whether it was a mix or whether it was from using different substances at different times, but we had meth and fentanyl appear in several syringes. And then we found meth, fentanyl, and xylazine in about 3% of the syringes, and then just xylazine in 0.5% of those syringes in July. And then for August testing results, we tested about the same amount, 337 syringes from Jefferson County. 78 tested negative for any detectable substances, and 259 tested positive for substances and adulterants. In August, fentanyl was the most frequently found substance, with 115 syringes containing fentanyl and 110 containing meth. And here's the breakdown of meth, fentanyl, and xylazine from August. So about 41% of the syringes contain just meth. About 37% of the syringes contain just fentanyl. And that is pretty, Kelly and Mike have let us know that that's pretty frequent, that it is much more likely to see meth without adulterants than to see fentanyl without adulterants. So xylazine and other adulterants are almost, if meth is found, and Kelly, I know you're here, so if I'm saying this wrong, please pipe in the chat. But basically, if adulterants are found in meth, it is very likely that fentanyl will be in that syringe residue as well. It's just much more likely for adulterants to be found in fentanyl than in meth.
Kacey, we have a question in the chat asking you to speak to where the syringes are gathered from in terms of
Yeah, absolutely. Thank you. Sorry about that. Yes, so the syringes, we work with several partner harm reduction sites throughout Jefferson and Fayette counties. And starting next month, when I talk about the September results, you'll hear more about syringes from Fayette County, as we've mostly been testing syringes from Jefferson County over the past 2 months. But we work with several partners, and our partners have asked to remain anonymous. So I can't give you the names of who they are, but they're programs that either distribute syringes or collect syringes through, like syringe sweeps, or both. And so that's where we're getting our syringes from. Does that answer your question?
Yes, thank you.
Great. All right. Thanks. And sorry that I didn't think to put that in there. But so yes, so as you can see in August, about an even split of syringes with meth and syringes with fentanyl. And then we saw between August and July, we saw a slight increase in the percentage of syringes with meth, fentanyl, and xylazine, like very slight. It's 3% in July and 3.1 in August, right? And about the same, but we did see an increase of syringes with fentanyl and xylazine without meth. As you can see, in July, it's a pretty small slice of the pie chart. It's that teal color, whereas in August, it is about 11% of total positive syringes that were positive, that had residue that tested positive. Any questions on the July or August testing breakdown before I start talking about notable contaminants that we found in July and August?
There's no more questions in the chat.
Okay, great. All right. So we found two contaminants that were really notable that we wanted to talk about here in July and August. So the first is carfentanil, which was found in 3 syringes from a Jefferson County partner site in August. Carfentanil is a fentanyl analog that is about 100 times more potent than fentanyl. And if you want to drop in the chat anything else you might know about carfentanil, that would be great. And then we also found medetomidine, which is a veterinary tranquilizer that is similar in structure to xylazine, in 46 syringes from a Jefferson County partner in August. Sorry. I should have said this at the beginning, but there's some work going on at my house. My basement was flooded, so I just got distracted for a second there. I apologize. Anyway, so medetomidine, which is a veterinary tranquilizer similar in structure to xylazine, was found in 46 syringes from a Jefferson County partner. And it was rarely found with meth, but was often found with both fentanyl and xylazine. And again, and Kelly, hop into the chat and correct me if I'm wrong, but I believe it was the only times it was found in syringes with meth residue were also times when there was fentanyl and or xylazine residue in the syringe as well. So I'm just going to break down, provide some information and some harm reduction information on both of these substances. So carfentanil, as I said, is a synthetic opioid and a fentanyl analog that's 100 times more potent than fentanyl. It's been found in syringe residue from Jefferson County in August. And then I was doing some research on whether fentanyl test strips detected carfentanil, because they don't always detect every fentanyl analog. And I found a really interesting study from 2024, which is linked in my reference slide. And also, once I hop off screen sharing, I can link that study in the chat. But it found that carfentanil is not reliably detected with fentanyl test strips. It's detected some of the time, but not even half of the time. That said, carfentanil is still an opioid, and naloxone can still reverse an overdose involving carfentanil, but more doses might be needed because it is so powerful. Sorry, my slides are having trouble advancing. So I just wanted to give some general harm reduction tips for carfentanil. We always recommend, as with any time you're using drugs, starting low and going slow. Carrying extra doses of naloxone if you can. Like I said, because it's so powerful, an overdose involving carfentanil might require more naloxone than a fentanyl or heroin overdose. I also would recommend practicing rescue breathing, becoming really familiar with how to rescue breathe, because if you are reversing an overdose, run out of naloxone, waiting for EMS to arrive, and the person still is not breathing, it's really important to perform rescue breathing until EMS arrive. As I'm sure everyone on this webinar knows, opioid overdoses are respiratory depression, or opioids cause respiratory depression, and an opioid overdose is just your breathing is so depressed that you stop breathing, or not just, but that's what it is. And so practicing rescue breathing is really important in situations where you don't have naloxone, have run out of naloxone. You want to make sure that you are keeping that person breathing, or if they can't breathe for themselves, you're keeping oxygen going in and out of their body. And then, of course, we always recommend that people don't use alone. It's best to use with a friend who you can trust to reverse an overdose if you experience one. And if people are using alone, we recommend calling the Never Use Alone hotline or calling a friend and being on the phone with a friend while you're using. And then if you have reversed someone's overdose, we recommend that you stay with them for 6 to 8 hours if you can, and if they're not willing to go with EMS, in case they overdose again once that naloxone wears off, because carfentanil is so powerful that is more likely to happen than it might be with less powerful opioids. Any questions on carfentanil before I talk about medetomidine?
There aren't any in the chat right now.
Okay, great. And I apologize if you hear my neighbor's dogs barking in the background. All right. And then the second adulterant we wanted to spotlight is medetomidine. As I said, it's a veterinary tranquilizer. It's been found in 46 syringes in Jefferson County in August. It is structurally similar to xylazine, but unlike xylazine, at least right now, medetomidine has not been associated with skin wounds. It has been associated with severe and rapidly occurring withdrawal symptoms, which often require intensive medical care, and I'll talk more about those in just a minute. A lot of what we know about medetomidine is coming out of Philadelphia because, like xylazine, it first started being seen in Philadelphia. One of the articles I read while I was researching and putting together this PowerPoint said that from the first quarter of 2025 to the second quarter, there was something like it went from something like 30% of syringe residue that was tested being found with medetomidine to 70%. So it is really on the rise in Philadelphia and in the surrounding states. And obviously it's been found here in Kentucky now as well. So I just want to talk a little bit about what medetomidine overdose might look like and what medetomidine withdrawal might look like. And just, I know that everyone on this webinar likely knows this, but just as a reminder, medetomidine is not an opioid. It is being found mixed in fentanyl. So we still, of course, recommend using naloxone to reverse that opioid overdose. But if an overdose involves medetomidine, it might just look a little different than a traditional opioid overdose, in the same way that xylazine kind of looks different when it's involved in an opioid overdose. So symptoms, oh, sorry.
One is asked in the chat if naloxone works on medetomidine, so I just want to make sure that what you just said then was clear, that you'd want to use naloxone because it might be mixed with an opioid, but no, technically it would not.
Yes, exactly. Thanks, Amanda. So symptoms of medetomidine overdose include heavy sedation, slow heart rate, low blood pressure, dizziness, physical exhaustion, and shortness of breath. So very similar to what we're hearing about xylazine overdoses, right? With that heavy sedation, hearing about people losing time or passing out quicker than they may with opioid overdoses, because it just hits people really quickly. And then symptoms of medetomidine withdrawal, which again can be very serious and often requires medical attention, include a rapid heart rate over 100 beats per minute, very, very elevated blood pressure, tremors, nausea, vomiting, and severe anxiety and rapidly changing moods. Any questions about any of this before I move on to some harm reduction tips for medetomidine?
I think you got them all.
Cool. All right, so harm reduction tips, again, start low and go slow, especially if you're, if you've bought from a new supplier or if it's a new bag. Just make sure that you are using a little bit to start. As I'm sure everyone knows and hears often, you can always use more later, but you can't take anything out once you've used, right? If someone looks like they're overdosing, use naloxone. Like Amanda just said, naloxone doesn't work on medetomidine itself, but it is almost always mixed with fentanyl or an opioid. So naloxone will still work to block those opioid receptors and take people out of opioid overdose. That said, because medetomidine can cause that can cause that heavy sedation, someone's opioid overdose might be reversed, but they may not. So once you give naloxone, someone might start breathing, but not wake up or be conscious or talking if there's a medetomidine or if there's medetomidine involved in the overdose. And again, it is really important to practice that rescue breathing. So medetomidine overdose, like an opioid overdose, causes respiratory depression. So it is really important to make sure that someone's breathing, even if they're not conscious, even if they're not up and talking. You want to make sure that you can see their chest rising and falling. And so I'm sorry, I should have put a slide in about this, but just to review, since I've mentioned it both with carfentanil and with medetomidine, for rescue breathing, what you want to do is you first want to check and make sure, open the person's mouth, check and make sure there's nothing lodged in their throat. And then you want to pinch their nose. If you have a rescue breathing shield mask, you should use that if that makes you more comfortable. And you want to always make sure that you can read what's printed on those shield masks because they're only one way. So you don't want to cause further blockages to someone's breathing. So make sure that that text is facing you and that you can read it. And then, so you'll pinch their nose closed, lift their head up, put your mouth on their mouth, and give a breath every 5 seconds until they start breathing on their own. And of course, if you're with other people and you want to trade off, we encourage doing that. Rescue breathing can be very draining. And then finally, seek help if you feel sick. Medetomidine withdrawal can happen very quickly. I attended a webinar hosted by a doctor who has been responding to medetomidine withdrawal in the emergency room in Pennsylvania. And he said that he's seen people come in 3-4 hours after using with really severe withdrawal symptoms. So it really can happen very, very quickly. And it often requires that medical attention. So if people are feeling sick, definitely encourage them to seek medical attention because there are actually, and I will drop this in the chat as well after I stop sharing my screen, but there have been some recommendations developed already for medical providers responding to medetomidine withdrawal. So that's really exciting to see that that medical personnel are taking it really seriously and that there is a prioritization being given to creating procedures for responding to these withdrawals. And that is really everything I have. I'm going to stop sharing and see whether there are questions.
Thank you, Kacey. That was great. There was a lot of participation in the chat and some questions
Awesome.
came through. I think they were all addressed as you were talking through the last couple of slides, but I don't know if you want to open the chat and just maybe scan through them.
Yeah, absolutely.
Awesome.
Yes, and thank you, Amanda and Rachel, for talking about the test strips and Kentucky Harm Reduction Coalition working to get those test strips. So I see Danielle's question about whether people need to go to the hospital if they're overdosing, and I don't know whether that has been addressed yet, but I would just say if you're giving someone naloxone, like anything else, if something looks like it might be an opioid overdose and you're giving naloxone and the person is not breathing, not responding, not waking up, that's why we say to call 911, right? Because respiratory depression can happen for a number of reasons. So yes, if someone looks like they are experiencing an opioid overdose but is not responding to naloxone, we definitely encourage seeking medical attention for that. And thanks to Mike for pointing out that there's no antidote for medetomidine, and that people who are receiving treatment are receiving fluids and epinephrine. And yeah, let me find the things that I said I was going to drop in the chat. I do see that Amanda dropped that medical recommendation for medetomidine withdrawal already. So let me, here's and then I'll drop the link to that test strip study, because I do think it is really interesting just to see what analogs, what fentanyl analogs people do or are and are not being detected by fentanyl test strips. And I think it's also just really important to remember that, fentanyl test strips are a great tool, and also they don't give us the full picture. So we always want to be encouraging people to start low and go slow, be using with friends, be carrying naloxone, and call 911 if they feel safe doing so, and if an apparent overdose isn't responding to naloxone. And that's everything from me. Marie is saying is asking whether it's becoming a more prevalent substance in Fayette County. We have not found medetomidine we've only tested, in August, we only tested a few syringes from one partner site in Fayette County, and we didn't find medetomidine in any of those syringes. But so I can't speak really to whether it is becoming a more prevalent substance in Fayette County, but Jefferson and Fayette are not far away from each other. And so I would say, and anyone from the Harm Reduction Hub also, please feel free to jump in. But I would say if something is appearing in Jefferson County, I would always expect that it would be in Fayette County soon after, if not at the same time, right? But we hopefully will have a better answer for that in October.
Great. Thank you, Kacey. So while you're working on putting those things in the chat, I'm going to turn it over to Martha. I'll introduce our next speaker real quick. Our next presentation today is given by Martha Tillson. She is a sociologist by training and an assistant research professor in the University of Kentucky College of Medicine, Department of Behavioral Science, and Center on Drug and Alcohol Research. Her research centers on individuals' experiences of substance use and related risks, with a focus on factors and services that support harm reduction and recovery, particularly interventions leveraging the expertise of peer recovery support specialists. Dr. Tillson has led and/or contributed to many community-engaged projects focused on substance use services and supports for individuals with diverse recovery pathways. Her recent work in collaboration with Voices of Hope has focused on stigma related to medications for the treatment of opioid use disorder, intersectional substance use stigma, and development of harm reduction materials for use by peer supports, which she will be presenting on today. This work is motivated and informed by her academic background in psychology and social work, desire to reduce stigma and drug-related harms, and her lived experience as a person in recovery. Welcome, Martha.
Thank you so much, Brooke, for that introduction, and to Voices of Hope for inviting me to come speak to you all today. I am super excited to be here. Let me go ahead and get my slides up. You all see that okay?
Looks great.
Fantastic. All right. As I said, very excited to be here today, and especially excited to see so many familiar faces. That was a great presentation by Kacey, and I think that we can all agree that the work being done by the UK Harm Reduction Hub is critically important, right? We need as much up-to-date information about the drug supply as we can get in order to keep ourselves and our loved ones and our communities safer. But I think that many of us would also agree after seeing Kacey's presentation, and Kacey did an amazing job, I think, breaking it down for all of us. But I think we can all see how this information has the potential to be pretty complicated. I'm not a chemist. Most of the names of the adulterants look kind of like alphabet soup to me. And I could easily understand how someone in the community, someone who really does need this information, might be quickly overwhelmed just seeing the results themselves, right? What does this mean? Should I be worried? What can I be doing to keep myself and the people I care about safe? And I know these are good questions because you guys were already asking them in the chat. But that brings us to the project that I will be presenting today. So we knew that these results from the Harm Reduction Hub contained information that we needed to get into the hands of community members. So we set out to co-create a toolkit that could be used to share those results in a meaningful and understandable way. You may even have already seen the final product if you follow Voices of Hope on social media, but in either case, I hope you'll be interested to know more about the process that went into developing them. So before we get started, just a couple of quick acknowledgements. This project would not have been possible without all the folks that you see on this slide, my fellow investigators, Amanda Fallon-Bennett and Rachel Vickers-Smith. Project support from Haley Harden and Brenna Hardy. I saw Haley's on the call today. Hi, Haley. Graphic design from Ethan Hawes. They did an amazing job. I can't recommend them highly enough if anyone has graphic design needs. Community partnership with Voices of Hope, of course, and funding provided by the Good Samaritan Endowment. We also do want to disclose a conflict of interest. As many of you know, Amanda Fallon-Bennett is also a co-founder of Voices of Hope. So I want to start off with a question for you all, because this will be a lot more fun if it's not just me talking at you this whole time. So let's have some fun in the chat. No right or wrong answers here. But when I say drug checking, what comes to mind for you? What does the phrase drug checking make you guys think about? Yeah, testing for adulterants, seeing what drugs are in the area, test strips. Yeah, I see a couple of people saying test strips, seeing what is inside a drug. Yeah, absolutely. Yep, test strips, testing the supply. Yeah, reviewing drug screen results. That's a good one too. I hadn't even thought about that. Risk reduction. Yes, so important. Yep, labs. Yeah, also labs, test strips. Yeah, absolutely. These are great answers. Did you get what you paid for? Absolutely. So these are all really great responses. And that's exactly what I was thinking of too, right? I think that when a lot of us think about drug checking, the first thing that comes to mind are test strips. So personal use checking approaches like, fentanyl test strips, xylazine test strips, benzo test strips. There's a lot of different flavors, right? But there are also programs, when we're talking about drug checking, there are also programs that allow individuals to bring samples of substances to people who can provide more nuanced drug checking analysis. So these are typically services offered out of buildings like an overdose prevention center or mobile vans. The equipment is generally like a little bigger, as you can see on that slide in the photo. So they're generally not as transportable, but that's another strategy that people can use to test their drugs. And then there's even other programs that allow individuals to mail in samples of substances. So if a lab like this UNC Street Drug Analysis Lab has a lot of resources and capacity to do drug testing, they can accept mailed samples and then provide the results back to the person who sent it. And each of these approaches has positives and negatives, but one thing that they do all have in common is that all of them enable the person with the drug sample to directly know what is in their own drugs, which is really valuable, right? This is so important to help people make informed decisions about their use. But what if I want to know about the drug supply on a larger scale, not just the drugs I'm using, but the drugs that myself and the people in my community are using and what I should be keeping an eye out for? Which brings us to the UK Harm Reduction Hub. So I won't spend too much time going over this process. I know that Kacey already mentioned it, and I believe you've heard about it in some detail on previous webinars as well. But this is really why the Harm Reduction Hub is so important, because it is filling a gap in our knowledge as a community. So it's not just allowing people to find out what is in the drugs that they are using, which is definitely super important still, but what are we seeing as far as larger trends in the drug supply? But as I mentioned in the beginning, it's only going to benefit our community if we can figure out how to get the information about these results packaged in the right way into the right hands. So when we were thinking about how to get this information out there, one question was, who should be the messenger for this information? And we immediately thought of peers as being perfect for that job. So peers are awesome, as we all know, but do you all have any specific ideas why peers would be great at sharing new information about the drug supply? And go ahead and drop it in the chat. Trust factor, 100%. Credibility, yeah, y'all know what you're talking about. Lived experience, yes, also super important. I love that Dorothy said peers talk to each other. I think that's also really important as well. Lived experience, they do know what's out there. Yeah. Yeah, absolutely. Yes, rapport with patients. Patients will report their current experience or bring it in for us to destroy. Opportunity to connect. Y'all are so smart. These are great ideas. Yep, birds of a feather. So I think these are all things that I kind of been thinking about as well, but I love the way that you all framed them. So the first thing I wanted to mention is peers are kind of already doing it. Peers are already sharing this information, as y'all said. So peers are distributing the harm reduction supplies. They're providing education, harm reduction education, and referrals to harm reduction services for participants. I love Rebecca also added that y'all talk to a range of people. That's so important as well. You're not just talking to participants, but you're also talking to other professionals working in these spaces that might also have information about it. As I also saw in the chat a couple of times, but peers are also perfect for these conversations because they build non-judgmental, supportive relationships with participants that are grounded in lived experience, right? Y'all know what you're talking about. Y'all have been through this. And that's really important when we're having these conversations. And lastly, peers are very well positioned to share this information because, as we've been talking about in the chat there, peers talk to lots of different people, and especially people at different points in their recovery. But peers are also talking to friends and family members too. So really effective at getting this information to as many people as possible. And on top of that, peers hold a position in the recovery community where they all are well respected and they are looked at as experts in this area. So because of the expertise of peers, we decided to use a co-creation approach to developing this toolkit. So as you can see in this diagram, when I talk about co-creation, that's kind of a sciencey term, but the process I think is really intuitive. So it involves connecting, first of all, connecting people and ideas, connecting teams of experts like our investigators and our research team and the expert recovery coaches and folks working at Voices of Hope, connecting people and ideas, discovering facts together, exploring and understanding the background of a problem or an issue, sharing the conclusions with each other, sharing what we're learning with each other, coming to a decision, making an agreement and coming to a collective decision about what course of action to take. Then creating, that's the create part of this co-creation, creating solutions and then implementing those solutions in the community. And so the most important part of all of these steps is that all of them are carried out as a team rather than having decisions made from the top down. So in some situations, a very smart researcher will come into a community or an organization and say, I have a great intervention. I've worked really hard to develop it. It is grounded in science. Here you go. Let's do this. There are some situations where that is appropriate, but in this situation, this was something that we really felt wanted to be grounded in what you all had to say, what Voices of Hope had to say, because if peers were going to be tasked with sharing the drug checking results, we really wanted peers to be engaged in this process of figuring out what that should actually look like. So to share a little bit about our methods in this co-creation process, we had 5 phases that were carried out over the course of just 3 months. So this was really, really fast, right? And I'll walk through each phase in detail in the slides to come, but just to kind of give you the 10,000-foot overview first, we started off in April 2025 with the creation of a found media sample library. So collecting the information, right? Finding out what's out there, what the possibilities could look like. And then in the second phase, in the next month, starting in May, we conducted 3 focus groups with recovery coaches to get their perspectives on this process of sharing drug checking results and also their opinions about the different methods, the different toolkit options that we had found. Phase 3, later that month, we developed a draft of a couple of different options for dissemination tools, right? So a draft of an email, a flyer, social media post. And then in phase 4, we circled back around and we did another focus group, but this time with administrators at Voices of Hope at the Recovery Community Center to more specifically get their feedback on those draft materials that we had developed. And then in phase 5, which was later in June, we refined the draft materials. We considered them finalized, and then we went ahead and launched. So as you can see, this was a pretty rapid process as far as from beginning to launch. But as I said, we'll go ahead and walk through these phases together. So beginning with phase 1, our graphic designer, Ethan, who I mentioned, put together this found media sample library for us. And it's kind of hard to really see in this screenshot, but I cannot understate how truly impressive this undertaking was. Because we thought it was important to start from a place of understanding how other organizations were sharing their drug checking results. So Ethan developed this rigorous search methodology to find these sample materials like the ones that you can see up on the screen. So there's things like social media posts, there's digital alerts, there's flyers, posters, a couple of blog posts, infographics, reports, public health campaign materials. And then they also created a scoring methodology to help us gauge the relevance of each of the portfolio samples to what we were hoping to accomplish through our project here. Each portfolio item, this is the degree of detail here, each portfolio item was also tagged with terms to help us narrow down our search, like the source of the item, if it was from Instagram or Facebook or a report, what drugs were being discussed, is it fentanyl, is it prescription drugs? The type of item, like if it was a poster or report, whether there were illustrations, is it text-based, are there infographics, just so much really rich information. And this was really a critical step for us to understand the broader landscape of messaging approaches, which for me at least was a pretty new area. So I was really glad to have this foundation. Yeah, absolutely. It was a great resource for us for sure. And then in phase 2, we took this information into phase 2, which, as I mentioned, this was our first round of focus groups, which was focused on recovery coaches employed by Voices of Hope. We conducted 3 groups over 2 days, including 28 coaches total. I like to share demographics on our groups. So most of the coaches overall were women, 82%, 86% identified as non-Hispanic white, and most folks were in general between 36 and 55 years old. And the overall goal in these groups, as I kind of mentioned before, was to really better understand how coaches think about drug checking, how they talk about drug checking with their participants, and to get their initial thoughts on different types of messaging approaches and designs that we were considering using. But before we dive into what we heard in these focus groups, I do want to share a little bit of more information about our participants, because I think that this kind of information is important to give some context to the feedback that we received. So as you can see, 50% of participants have been in recovery for between 2 to 5 years, 39% have been in recovery for 5 years or more. So most have been in recovery for quite a long time. And our participants also worked in a variety of different service settings. So those of you who are familiar with Voices know that there are coaches who work just in the brick and mortar RCC, that was 36%. But there are lots of other folks working in other settings out in the community. So the opioid treatment programs, buprenorphine clinics, criminal legal settings, syringe service programs, and then a couple from the RCC mobile units. So this means, I share this because to me, this means that when the coaches were sharing feedback, they were thinking about sharing drug checking results with participants across all of these different spaces and what that could look like. That was really important to us, that the toolkit we were developing be appropriate, not just for the RCC, but for all of these other spaces where peers are currently located. Recovery coaches were also asked whether they had personal experience with harm reduction services, and the majority, 79%, said that they had. So the most common experiences were using a syringe service program in the past or having used naloxone on another person. But a lot of folks said that about a third, 32%, said that they had personally ever been revived with naloxone. Just over 20% had used fentanyl test strips themselves. And then folks did also report having used the Never Use Alone hotline or drug checking notifications. We didn't have any peers reporting personally having used xylazine test strips, but still you can see that there's a range of experiences. And I think, especially as we're thinking about drug checking as a really important form of harm reduction, I do think it's valuable to see here that most of the coaches that we were asking for feedback did have direct relevant lived experience in this area. So lastly, we asked coaches to describe what had been important to them in supporting their recovery. And I also want to share this to highlight that coaches also had diverse recovery pathways. So about half said that recovery support meetings have been important. About half had used medications for opioid use disorder. Again, I think that's really important to highlight. Lots had used professional peer support or sober living, residential inpatient treatment. And again, I think that this is just valuable context to have when we're thinking about what these coaches have to say and being able to put that in context. So let's go ahead and take a look at some quotes from coaches in those focus groups. We first asked coaches for their general thoughts about having conversations with their participants about drug checking and harm reduction. And one coach said, I was explaining to somebody last week about xylazine. We had a webinar on xylazine and I got a lot of information from that. So I was better equipped to have an informed conversation with my participants about it. So coaches wanted to know more to help their participants know more. Another coach said, it's going to get the word out. I mean, you're going to discuss it with one person, they're going to discuss it with the next person, and word travels really fast. So the coaches understood that sharing information helps teach others to teach others, making sure that this information gets to the people who need it most. And then another coach said, I feel like with our participants, it shows them we care. Like, hey, this is what we're hearing. We just want you to know this, what's going on, because we care about you and we want you to live. And I love this one because to me, this highlights that talking about drug checking and harm reduction in general is really an expression of caring. You know, you're wanting this person to be safe and to stay alive. I want to pause and just ask if anyone wants to drop in the chat. What do you guys think about these quotes? Do you agree with these coaches, or do you have anything else that comes to mind when you see these quotes? Feel free to just drop stuff in the chat. Give me a break from chatting at you. You guys agree with what the coaches had to say? Thanks, Bobby Joe. Yeah. Yes, thank you, Brooke. I loved that too, how education is a sign of caring. That to me was really, really important. Yes, Kevin, very empowering. 100%. Yeah, Tony, keeping conversations open and allowing folks to give info is very important, 100%. Yeah, thank you all for chiming in. I love these quotes. I felt like they really, there were so many good quotes that came out of this conversation. But these I felt like really exemplified some themes that I thought were very important. Yeah, Jamie says truth plus grace equals love. Absolutely. All right, well, also as part of these focus groups, like I mentioned, we showed the coaches different examples of media that was drawn from that found media sample library that Ethan had put together for us. And this included things like flyers. We showed coaches text alerts. We showed them examples of emails. We found a couple social media posts to share as well. There's one from Facebook and one from Instagram. And then we also took a look at some website layouts. So lots of different options. But we looked at each type of media one at a time. So like, here's the flyers, here's some example of text alerts, here's some examples of social media posts. And we asked participants to share their thoughts on that media's strengths and weaknesses. So what is this doing well? What could they be doing better in this? We asked about information that we should be including or not including, right? What is really important? What do we need to know? What's maybe not so important for us to have? We also asked what they thought was useful about the post or about the different medias, or what was visually appealing, what did they think was pretty, what did they think was eye-catching, and then also the reach of the approach, which is very important. So using this strategy, whether it's text alerts or flyers or social media, who's going to get this information if we use that approach, and who might be left out? So the coaches, of course, shared some really great suggestions with us. And again, I pulled together a couple of quotes here that I thought really kind of highlighted what they had to say. One coach said, I feel like being in addiction myself at one time. Like if somebody's like, hey, there in this county, there's 200 overdoses in the past 30 days, like that would kind of scare me a little bit, make me stop and think. So the information should be attention grabbing, like what are the facts, what's the impact of this adulterant, and why should we be paying attention? Another coach said, I think just the facts, like just the quick facts. Hey, this is what we know, and this is what you can do, and here's a resource if you need help with it. So just keep it straightforward, right? Not put too much information in there. Another coach said, if there is anything you can do to reduce the side effects or minimize any negative harmful effects. And these are a lot of things I heard echoed in the chat when Kacey was presenting as well. But what can I do about it, right? That is so important that people know that front and center. The graphs and stuff should be the kind that are not difficult to understand. So if including visuals, we needed to make sure they were easy to read. Colors get your attention. The duller colors, like no. So bright colors, make it eye-catching, make it pretty. And then the last coach mentioned, maybe not for participants, but for me, the more information, the better. That way I can be more prepared to prepare them. And I think this one underlines the importance here that if we can get the information into the hands of coaches and help them understand, they can help translate those findings for their participants who will share with other participants, and so on and so forth. So after these 3 focus groups, we regrouped, we reviewed the recommendations from the coaches, and we shared those recommendations with our graphic designer who created some draft toolkit materials for us. We asked them to focus on 4 different options. So we narrowed it down a little, thinking that these would have substantially different appearances and language and reach just based on our discussions with the coaches. So we wanted to develop a flyer with the idea that it could be hung in the RCC and or shared one-on-one by coaches working with participants, which could be a good way to reach people who don't have a phone, right, or who aren't on social media. A social media post, this is something that can be eye-catching, visual pictures, wide reach, easy for folks to share. We wanted to develop a video script that could be used to film a video for like a TikTok or an Instagram reel. Lots of the coaches mentioned that people seem to engage with videos more. This might be more of a younger audience, but if we can package the same important information in multiple ways, like a video, a flyer, all that, to get more people and reach more people, that's definitely a good thing. And then lastly, an email that could go either directly to RCC staff or out to the larger Voices of Hope mailing list, thinking that that kind of structure could have the most information, links to other resources, graphs, statistics, things like that. So once we have these draft materials, our next focus group, which was about a month after that first round of focus groups, moving quickly, right, was with leadership at the RCC. So managers, supervisors, etc. And in that, it was just one group. We had 11 participants total. A little over half were women, 82% non-Hispanic white, and the majority of these leadership folks were between 26 and 45 years old. So at this point, remember, we had those draft materials, and the goal was to share the drafts with folks in this focus group to get their specific feedback on the next round of revisions. And we also thought that the managers and the supervisors might have a different perspective than coaches. Well, we had the idea that coaches would be delivering the information themselves. Leadership might see things from more of a big picture lens, especially when it comes to harm reduction approaches and sharing information about drug checking and the drug supply. So it turns out that leadership and coaches were actually pretty consistent. And I have a quote that I wanted to share because I just really love how this participant phrased it. People that go to syringe service programs trust those individuals because they do give you information about the drug supply. Or people that visit recovery community centers, they trust the people there. Like if we say, hey, there's a new drug out there, you need to watch out, be careful. Here's more information about it. And they take that, and then that gets to the word of mouth, and they get that involved with the people that they use with. And it's kind of how it spreads, I guess. And I wanted to share this quote because I think it really exemplifies the tone of that group. So all of the RCC leaders in that room really believed that there was an important kind of trust between participants and coaches. So it was important to get this information out there so that it could spread through the community. Participants in this focus group did also, of course, share feedback on those draft materials, which overall was pretty consistent with what the coaches had said in the last round, just more targeted to the actual drafts that they were viewing. First, make sure language is simple and accessible. Don't use words that are going to go over people's heads. Make sure it's at a basic reading level, easy to understand. Don't make people work too hard to get the information that they need. Using attention grabbing visuals and readable fonts, right? Make it grab people's attention. Again, don't make it too complicated. Date and location of alert clearly indicated. This one was a really important one, especially when we're talking about things like social media that live out in the world forever and ever, right? And if somebody comes across an old post on Voices of Hope's site, for example, on social media, and it doesn't have a date like clearly printed or a location clearly printed on it, they don't know whether or not this is current. They don't know whether or not it's impactful for them and information they need to worry about. So making sure that that date and location was really emphasized. We also got the recommendation from this focus group to frame materials for people who use drugs, who are definitely going to be folks that this would be relevant for, but also to frame it for loved ones and other community members. And I especially appreciated this perspective because information about drug checking is really for everyone, right? We all have people we love who use drugs if we're not using drugs ourselves, and just making sure that everybody is invested in helping folks to stay safer and stay as safe as possible. And then also to hit the key points, which they saw as what is the adulterants? How do you detect it? How do you know if it's in your sample? And how can you respond? What can you do to either prevent issues and keep yourself safe, or what can you do after the fact? You know, is naloxone effective, or do you have to seek emergency medical attention? But what should I do if I do experience this? And then finally, highlighting community resources. This is so important, right? If you can use test strips to detect it, where do I get those test strips? If Narcan is effective, making sure folks know, where do I get Narcan? And especially if these are materials, if this toolkit is designed to be shared from the RCC, making sure folks know that the RCC is open to them and there for them, and what kind of resources the RCC provides that can help them with these problems. So we then shared all of this great feedback with Ethan, which helped them to make the final edits to the materials. They shared this back to us. They did an amazing job, as I said. Highly, highly recommend them. And that brings us to phase 5. And I am excited to share that Voices of Hope has since launched these toolkit resources. As you can see from these social media posts, these are just from last month. So you may have already seen those. And we're so excited to see this, first and foremost, because like I said, this is getting those results, like the ones that Kacey shared in the last presentation. This is getting those results out into the community, and it is letting folks know when and where those results were found. You can see the date in the county is right up there. What the adulterant is, right? Otherwise, you know, I wouldn't have known if you just put the word medetomidine in there. I would have no idea, right? But you can see that there's a little description. Medetomidine is not an opioid, but it is sometimes found in illicit fentanyl, right? Information like that is so important. And then also what to do to keep yourself and your friends safe. Yeah, Jeannie, these flyers are awesome. I'm so excited about them. And so all of these too, because these are Facebook posts, right? So all those little tiles down on the bottom, you can click on those and you can make them bigger. You can zoom in on them. You can get that information. So now that you all can see these final results, especially since I won't name names, but we are fortunate to have some folks who participated in the co-creation process with us here today. I would love to know what would you guys suggest now that you can see these final results? Is there anything we can do better or do differently, or what do you all think about these? Love, love, love. Thank you, Michelle. Thanks, Courtney. That's definitely helpful. A little busy. There's a lot of information, right? It's a balance between wanting to have all the information in there that people would need, but not overwhelm people, especially if they're scrolling by it real fast. Yes, Brooke, totally. Brooke says, I think date and location is so important. I have fallen for old weather predictions before. Same. Oh, Kelly, awesome. Kelly says she's been passing them out to all the participants that come into the SSP. Yes. Yes, Kathy, absolutely. Yeah. Yeah. I feel like sometimes with these Facebook layouts, it can be hard to see the small information, like with the tiled photos. It can be hard to see that. And we hope that people are going to click on them and make them bigger so that it's easier to read. But yes, Laura says print and post about the needle collection boxes at the RCC. Awesome. Making sure the town and state are on there. Yes, Stephanie. Yeah, that was something that we really thought was important as well. And I know that even came up in the questions when Kacey was presenting, like, where exactly is this happening? Is this, relevant to our participants here? Again, even if it is in a county outside Fayette County, we do, want people to still be aware because, substances move very quickly and it's very possible that it could be coming our way soon, but we don't want them to like panic unnecessarily if there isn't an immediate issue. Awesome. On the bulletin board at KCIW, that's a great spot. Absolutely. Yes, Katie, that's a good question. That information should be in there if you click and open some of the little pictures, but definitely hard to see just on these screenshots here. Thank you all for all this feedback. This is so helpful. Like I said, I'm very, very proud of the work that we did together, and I'm very happy with how these came out. But I also understand that there are always going to be things that we can do better, right? So even as you all, see these posts, see them on Facebook, or print out the flyers and share them with folks. If you have suggestions and any feedback, please reach out to the Harm Reduction Hub and let us know. Because again, we created these through the focus groups and the co-creation process. But once they kind of get out into the community, that opens us up to a whole bunch of other folks that can help us understand how to do this better as well. So if you do have suggestions, we would love to hear them. So to wrap up, I wanted to share just a few thoughts about what we learned through this process. So the first one I wanted to highlight is that peers and RCC leadership were all very enthusiastic about the value of harm reduction and drug checking. And this enthusiasm, to me, this is so important to make sure that we are getting this information out there, knowing that we have a partner at Voices of Hope who believes that this is valuable and that wants to get this information out into the community. Another conclusion that I wanted to highlight is that peers can be effective conduits or pathways for new information about the drug supply, right? Peers are the ones for the job. Ideally, right, this is a community enterprise, and this is something that all of us have a part in and all of us are invested in. But for peers specifically, their lived experience, like we were talking about, it gives them credibility. But it also lets participants know that they are sharing this information, that you all are sharing this information from a place of love and caring, right? Harm reduction really is love. And lastly, this co-creation process that we went through together resulted in a toolkit of materials that was relevant. It was informed by a lot of very valuable, very different perspectives, and it was grounded in community feedback. So we could really have confidence in what we built and what we created together. Like I said, there's always going to be things that we can change and do better, but we can really feel strong about where we're starting from and the place that we're starting from. So what's next, you may be thinking? Our next steps at the moment, we definitely want to continue to use these toolkit materials to share the UK Harm Reduction Hub drug checking results and to monitor implementation as they're going out into the community. So I love hearing about people who have seen them on Facebook and that we know that it's reaching folks, or where you're putting up those flyers. Thank you all for sharing that. I really like seeing how it's moving out into the community. We also want to scale up the distribution of the toolkit to other recovery community centers. So we went through this co-creation process with Voices of Hope, and it was informed by all the folks at Voices of Hope, and it's now being implemented by Voices of Hope. But we want to see, how does that work out in the wild, right? Because this is important information for us, but it's important information for folks all across Kentucky working in recovery community centers. So how can we scale up the distribution of these materials and share it with other community centers that could also benefit from it as well? And of course, we would like some more money to be able to support this work. So I do plan to apply for some pilot funding to assess implementation in other RCCs across the state, just to see how that process is working and gather some results for that as well. So let's see, I see Katie has a question, still may be missing something, but I'm looking at a Facebook post on Voices Facebook and still don't see clearly where to get naloxone or test strips. Yes, thank you so much for checking that, Katie. We can definitely make sure that that gets added. That is super, super important. Yeah. Well, I did want to make sure to save some time at the end here so that we could talk. My email is here. I always put my email up at the end because if anyone wants to reach out to me directly, I know lots of you know, I really do love hearing from you. So if you have questions, if you want a copy of the slides, if you're just interested, if you want to chat more about this project, please feel free to take a screenshot. I'll also drop my email in the chat, but I would love to hear from you. So I'm going to go ahead and stop sharing at the moment.
Thank you, Martha. Maybe put your last slide back up there in case people were still getting your email.
Oh, yeah, you're right.
And we have lots of things happening in the chat. The link for the for peer support specialists to get continuing education credit, that survey link is in the chat. So is the link for our webinar archive if you'd like to visit those recordings. And Amanda also included the Harm Reduction Hub mailing list if you want to join that. And I believe Kacey mentioned that the first newsletter is going out tomorrow. So lots of activity in the chat.
That is so exciting. I'm really excited to see that newsletter.
Me too. I'm just looking at Kelly's question. Oh, this has been great information. Thanks. I'm so glad you're here, Kelly.
Yeah.
But Martha, I think like that presentation was so great. You know, the central question being, how does information spread? You know, how do we get information out there? And I love that you used recovery coaches and peer support specialists as resources. You know, they're at sit at such an amazing intersection to help spread the information, and just love that you asked for their feedback in developing this toolkit.
Yeah, absolutely. That was something that really, I think, stood out to all of us as well. And I love that so many folks are mentioning that in the chat as well, even early in the presentation, like peers are just centrally located in recovery communities, and peers really are looked to as experts by people, especially when we're talking about how do I keep myself safe? How can I mitigate the harms or mitigate the risks from this? And peers are talking to everybody, right? Peers are so often that bridge between participants and clinical providers or criminal legal system staff, or, you know, all kinds of other folks in the community that we can advocate to. And so peers, I think, are especially important to be able to share that information because they can share with everybody, friends, family members. That was definitely a really important part of this. I see Marshall highlighted that too. The collaboration with so many groups to put this together was awesome. I think so too. This has been my first experience with a co-creation in a formal kind of way. And it was really amazing, right? I feel like I want to do this for all of my research moving forward.
Well, it aligns with that tenet of harm reduction, nothing about us without us, and how you include the people who will be using the tool, you know, in the design of the tool. Have the people that it will affect be part of the decision-making process.
Yeah.
So
100%.
love it. Okay, I don't see any other questions coming through in the chat, and Martha really does mean it. You can email her questions. And we'll be adding this recording to our archive page that I put in the chat. Okay, anything else from you, Martha?
I don't think so. Just thank you so much to everybody for your time and for hanging on this webinar and listening to us. And for those of you who did participate in the co-creation process and were a part of that, just thank you for sharing your perspective and for helping us develop this toolkit into something that we are really proud to get out there into the community. So we appreciate you.
Great. Thank you, Martha. And thank you, Kacey. She had to leave early. Let's all send her well wishes to her flooded basement. And thank you all for joining the Kentucky Harm Reduction and Recovery Community of Practice webinar series. We'll be back next month, the first Tuesday of the month at 10 a.m.